So if you don't already know, I'm Dr. Shahida Alam from National Cancer Institute. And my confession, this is not a breakthrough research, just a little bit audit what we are doing, what the things should be, and how can we improve. Let's get started. So breast cancer occurs bilaterally in about 3% of all cases, among which synchronous tumors accounting for 1.6% and metachronous tumors for 2.2%. So what is synchronous and what is metachronous? Patient with bilateral breast cancer having 2 breast tumors diagnosed within 6 months defined as synchronous breast cancer, and contralateral breast cancer diagnosed after 6 months of the first primary breast cancer defined as metachronous breast cancer. So the background of this review to figure out the clinicopathological and immunohistochemical profiles of bilateral breast cancer patients. It's a retrospective review of medical records of 53 cases of bilateral breast cancer who attended the National Institute of Cancer Research and Hospital, Dhaka, and a private hospital was done. There was no time limit. So now coming to the result. When I look at the age of the patient, what I found that in case of synchronous breast cancer, the diagnosis of first cancer, the mean age was 42.94, and the median was 40, with a standard deviation of 11.573. And the range was 50, minimum 25, and maximum 75. And in case of metachronous, the age of first cancer, the mean was 38.43, the median was 38, with a standard deviation of 5.5 years, with a range of 26 to 48 years. Here we can clearly see that in metachronous tumor, the age is a bit less than the synchronous. So regarding the histology, that was my conception as well, that lobular carcinoma has a more propensity to develop bilateral or multiple breast cancer. But from my study, I have seen that about 90% was infiltrating ductal cell carcinoma, only 6% infiltrating lobular carcinoma, and others are medullary carcinoma, 4%. So still infiltrating ductal carcinoma is the most common histology. So the molecular biological subtype in case of synchronous first cancer. So I consider the one which is stagingly, which is more advanced. This is the first one, and the other one is second one. So the luminal A was 22.2%. HER2 type was 11.1%, TNBC 27.8%, not done in anyone is 5.6%, and triple positive 33.3%. So if I just add triple positive and HER2 type, that it is about 44%. So we can have an idea that HER2 type breast cancer has a more propensity to develop bilateral breast cancer. So the molecular biology of the second one, that is luminal A for 11%, HER2 type for 16.7%, TNBC 16.7%. I'm skipping the not done here. ER positive, PR negative, and HER2 negative is 11.1%, and triple positive is 11.1%. This slide that surprised me a lot, because a synchronous breast cancer, bilateral breast cancer, sometimes we jump to the treatment, but by just doing the receptor status of only one breast. So in 33.3% cases, the receptor status of the contralateral breast were not done. But what the science say? So it's not that always the two breasts that this cancer occur in the same time, the tumor biology will be the same. So what I have seen, that receptor status concordant, that is similar, the bilateral breast in 33%, discordant in 38%, and not applicable as missing of one is 39%. So there is every chance of discordant of this 39%. So we should consider two breast cancer as a two separate entity. So we should have the different plan for two breast cancer. One may be TNBC, another may be HER2 positive or hormone receptor positive. So staging at presentation at synchronous breast cancer, most of the patients presented in stage B and stage 2 and stage C. That is quite natural for our country. And staging at presentation of second synchronous metastasis is also reflecting the same. Stage 2 and stage 3 was the majority of the patient. So now coming to the metachronous breast cancer. So the molecular subtyping of first breast cancer, that was luminal A for 22.9% of cases. HER2 positive, only HER2 type is 14.3, TNBC 37.1%. HER2 equivocal, but hormone receptor negative is 5.7%. Not done for any reason is 17%. And ER positive, but HER2 negative is 2.9%. So here also I found the discordance between the receptor status in metachronous tumor, and what is very surprising that in second cancer, in case of metachronous, the rate of TNBC is abnormally high. Usually we have seen 30 to 35% TNBC in our maximum cohort, but in case of metachronous, it is about 65% for second breast cancer. So here the same thing, the receptor status dissimilarity, concordant for 31%, discordant for 52%, and not applicable as missing of one receptor status is 17%. So this is the first breast cancer staging presentation. As usual, most of the patient presented as stage 2 and stage 3, and some patient unstaged and stage 3 as well. So I would like to draw your attention in this slide as well, because when I was preparing this slide, so this was quite disappointing for me. A patient, so the staging of the second breast cancer, a patient having history of breast cancer who is in any form of follow-up, if the patient was diagnosed as a stage 3 or 3ABC, if you add all 17, 8, and 5, that is almost 27% patient was in stage 3. So they were they had been in any form of follow-up, but they were diagnosed in stage 3. That is quite disappointing for us. So my other observations, then 85% patients were premenopausal and 15% patients were postmenopausal. So most of the patients are very young patients. Majority of patients were in age group 30 to 40 years. Family history of breast cancer or other cancer was positive for 25% of patients, and BRCA testing was done in 5 patients, among which 2 were positive and 3 were negative for mutation. So this is my take-home message, or I would say from my observation, this message should be very loud and clear. Then patient presence with a breast lump should be evaluated by bilateral diagnostic mammogram, ultrasonography of both breasts, and MRI in special cases to exclude synchronous bilateral breast cancer. In my 53 patient in synchronous metastasis, 2 patients had to undergo mastectomy just 2 months apart because the opposite one was not evaluated for the first time. Only ultrasonography of affected breast was done. That was a unilateral ultrasonography, not a bilateral one. So this is the guideline. For synchronous, second one is for synchronous breast cancer, histology, receptor status, and clinical staging should be done for both breast primaries. This is very important. We can't take it for granted that both are same, both would be TNBC or both will be HER2 positive. They can be different, so their treatment plan will be different. And very importantly, we should not miss metachronous breast cancer. We have to pick the metachronous breast cancer in very early stage. That's why the follow-up. The only investigation, imaging investigation recommended by the NCCN guideline in follow-up of the patient is yearly mammogram. If the patient have mastectomy, then mammogram on opposite breast, and if the patient has breast conservation surgery, then bilateral mammogram. But we see right and left in the follow-up, ultrasonography, whole abdomen, chest X-ray, CA 15.3, but we miss the mammography. So clinical examination of breast in every follow-up, yearly mammogram of other breast if mastectomy, or both breast if breast conservation surgery, and patient's education. We need to educate the patient regarding the self-examination of remaining breast or the other breast. Thank you so much for your patient hearing.